Good evening. My name is Bailey Phillips. This is the Mobile Integrated Healthcare Program presentation for the EMS 4320 EMS System Design class. This is addressed to Professor David Grayson, and the date is August 9th, 2025, fresh off of vacation. If you hear any background noise, that would be my wife and daughter in the other room getting ready for bed, and I just wanted to knock this out while I could still talk freely because my house is not very big and I cannot talk freely while my daughter's trying to sleep. So just trying to get this knocked out. About myself, I am an active firefighter paramedic in Virginia, Chesapeake, Virginia specifically, and that's what we're going to be using for the presentation. I have 10 years of experience between several different departments, working in and out of the hospital, working for private transport on a critical care truck, along with doing 911, which is what I do currently. I have a wife of 6 years named Amber, a 4-year-old daughter named Ray. We just got back from vacation in Tybee Island. That's in Georgia. We go there every single year for a timeshare. We are also the owners of an inshore commercial dive company called Phillips Family Diving and Hole Services. That's my full-time job away from my other full-time job. I have an actual mobile integrated health history. I helped develop my department's current mobile integrated health program before I owned my own commercial dive company, and it's been fairly successful so far. And then this is my very last assignment before I get my degree, so just trying to make it a good one. MIH explained. The National Association of Emergency Medical Technicians describes MIH, Mobile Integrated Health, as a service intended to serve a range of patients in and out of the hospital setting by providing 24/7 needs-based at-home integrated acute care, chronic care, and prevention services. That is from Dr. Beck of the National Association of Emergency Medical Technicians. MIH is an evolving system that meets the needs of the community based off of the community's population. In an urban setting, MIH focuses more on navigation of services and resources within the community and kind of helps reduce hospital stays and reduce the amount of times a frequent patient that calls 911 would call 911. In a rural setting, community paramedicine comes into play a little bit more, where you'd actually be going out, assisting patients with medications, drawing labs, seeing at home like visits, kind of doing more home healthcare stuff. But in an urban setting, which is where my department is, we focus more on the navigation of resources and some other things that we'll talk about shortly. So for the Chesapeake MIH program, we're going to have two basic categories. The first category is going to be fall prevention program. These are for patients that have mobility issues, usually in the geriatric population. They call 911 pretty much once or twice a day. Sometimes it's even like once every other day. They're falling a lot, and we want to prevent that because we don't want them to get hurt, and we don't want our providers to get burned out going to the same people all the time. So what we would do is provide donated durable medical equipment to help with their mobility. So canes, walkers, wheelchairs, grab bars, anti-slip stocks, a bunch of different things that we could provide to try to help eliminate their falls. And in turn, we would reduce the call volume, we would reduce the burnout on employees, and overall help the patient not fall and prevent their injuries. Multi-visit patients is pretty much the catch-all for all the other patients that might get referred to MIH. It's designed for all the people that call 911 frequently, except for the falls. So a lot of what that would be is a social worker going out, and they're going to navigate resources. These resources can include like free mental health assistance, healthy eating programs for people that are significantly obese or have diabetes, medications, kind of like somebody who's struggling to either get medications or figure out how to take them appropriately. We could go out and kind of give them the assistance without crossing it into the community paramedic world. And this would also reduce call volume and burnout to the employees. And that's just kind of the catch-all that MIH is really for. It's to help the community, but it's also to kind of help our departments and our department shareholders and the local hospital shareholders. So everybody really gets involved with this program. The command structure for our department is going to be, like I mentioned earlier, we have a mobile integrated health program that I helped structure. This is how I wish it was structured. It is not structured this way. So this is my dream wish for mobile integrated health, how I wish it was structured. For non-sworn employees, which is sworn into the city of Chesapeake under oath as a service member, essentially, the non-sworn employees would be the program director, the program director's assistant, and 2 social workers. The sworn employees would be the chief medical officer, which is the overseer of the entire medical side of our fire department and EMS agency. The medical director, which is the medical director for our department, the doctor that sets all the rules of what we can and can't do. The lieutenant of the program that kind of oversees the 8 emergency medical technicians and the 4 paramedics. And these would all be overtime positions. This would not be, it'd either be an overtime assignment or a light duty assignment for them. They're more of an aid to the program rather than the non-sworn employees who are there full time. The buy-in for the mobile integrated health program would include the community buy-in because we want to make sure that the community is for this program. So how we would get the information out about mobile integrated health and how we can help is through local events. We could go to 55 and up communities during their meetings. They usually do one once every week, maybe every 2 weeks. We have in the city of Chesapeake, I want to say 24 55 and up communities. So we are in there quite frequently. And then the last thing that we would do for the community is the posters and billboards, just to get the program out there. The local government buy-in is going to be the more complex one because that's where we're going to get our money from. So the Cost Benefit Analysis Center, the CBA, for the local elected officials would be kind of explaining to them what the cost benefit analysis would be to make sure that they're saving money, and that's what they really care about. They just want to make sure they're saving money and we're improving the community while saving money. Same thing with the shareholders for the local hospital. They want to make sure that they're saving money, and how they're saving money is they're not receiving these patients over and over and over again. So that same patient that might call 911 7 times in a week might actually get transported to the hospital 4 times in a week, and they're not paying their bill. The hospital's fronting that bill. And so you times that by 30 patients, there you go. You got several hundreds of thousands of dollars the hospital bill has to eat. So if we can eliminate these patients from having to go to the hospital as frequently, it helps the burnout in the hospital and also helps financially the hospital shareholders. So the local agency buy-in would be the easy one to get. We would just pretty much say, hey, we have this problem. We know you guys are going out to these patients a whole lot. We're going to reduce that at no cost to you. And everybody will usually buy into that. So the funding for mobile integrated health, the first funding would be the one-time cigarette tax of 20 cents that will be added to each pack of cigarettes bought in the city. That'll last for about 2 years. So we're hoping to generate right around $200,000, a little more than $200,000 worth of revenue in a 2-year time span. We're also going to be looking at a couple different initial grants for the funding for the program. Even just one large grant from the government might be able to help us out, just kind of kickstart, get some of the equipment right off the get-go, get some of the training done for the employees. Some of those larger upfront costs we're hoping we can get under a grant. So that's in the future moving forward. Once the program has been proven as beneficial to the community and financially to the government and the shareholders, a more permanent solution for funding can be determined. So hopefully we can actually get it included into our annual budget for the fire department / EMS department from our city government once we kind of prove its worth. The training that is needed, sworn paramedics will need to get their community paramedics credentials as laid out by the International Board of Specialty Certifications, which does all of your SWAT paramedic, community paramedic, critical care paramedic, and flight paramedic certifications as far as the EMS world is concerned. The sworn emergency medical technicians will go through an internal department training hosted by the chief medical officer and the medical director. Social workers will hold at minimum a bachelor's degree in social work. The manager will be an outside hire with a minimum of a bachelor's degree in program management, but preferably a master's. or higher. The assistant manager will have a minimum of an associate's degree and just be able to kind of understand the basic fundamentals of the assistant role, and will assist in any of the tasks the manager pretty much sets out for the assistant manager. As far as the evaluation process goes, this program will be evaluated by the agency quarterly internally just to make sure that we're still hitting our margins of what this program is supposed to be used for. It will be evaluated annually by the local government, making sure they're still saving money, annually by the shareholders of the hospital to make sure that they're still saving money. Evaluation will consider the financial benefit of the program, its growth, and the employees within the program. A survey will also be sent out to all of the clients, because we don't call them patients when we go out to them. We call them clients. That's just going to be something that we push forward in the future. And all of our clients will make sure they get a survey at the end of the year to see how MIH either benefited them or did not benefit them. The evaluation continued. This program's initial evaluation is projected to be successful. It will reduce call volume. It will reduce falls and injuries to the geriatric community. It will assist in navigation of resources for multi-visit patients from the 911 and the hospital setting. And without proper education and outreach to the community, the only negative is without proper education and outreach to the community, the program could seen as a negative to taxpayers. And that's just really more rumor mill. When people don't know the truth behind something, they start to create a rumor saying they raised our taxes, just the general tax fund, to fund this program that's not benefiting them directly. If they don't know the whole truth behind something, then the rumor mill can spread very quickly. So we want to make sure that we're very upfront and outreaching as far as where we got our funding from. Yes, it was an initial tax increase, but for a specific tax on cigarettes. So if you buy cigarettes, sorry about your luck. You got to pay the extra 20 cents. And hopefully we can get the program out there enough where people won't have that speculation. So qualitative research. So qualitative versus quantitative. I lean more towards the research of the mobile integrated health being qualitative research. And that is because the data collected on the evaluation of the mobile integrated health program will be more qualitative. It will focus on data collection through surveys within the department and the public. We'll focus on the meaning of the data and the impact within the community rather than just full-on statistics. But it will have a small quantitative piece of data collection using the call volume data collected to determine if the call volume reduction was successful to the frequent callers of 911. In summary, the mobile integrated healthcare program is the future for EMS. MIH can be adaptable to fit the needs of every community and everyone's community. For our community within Chesapeake, we will focus on multi-visit patients and frequent fall patients. The last slide. This is the last slide and assignment I will be doing for college. I will not be going further for my master's degree. I do not have a need within my department, and also running my very successful business. I don't really need. My initial plan was to move further, but at my point in life, running the business has kind of taken priority, and being a family man has taken priority. So this is my last slide for college ever. I'm very excited to get my bachelor's degree and be done with it. I'll be eligible for promotion, which I might do within my department, but that's about as far as I want to go with life. I've made up my mind. So without further ado, this is the last slide and assignment that I will be doing for college. I just want to say thank you for the guidance in this last class, and to Columbia Southern University for the opportunity to get a degree I never thought was possible, just from a small town blue collar country boy like myself. Thank you. I am so excited to be done. And I do want to say that thank you to the professor of this course for allowing me to give this presentation and say my thank yous. So these are my references, and then I just thought it was funny because I made that whole last slide, and I said, you know what, I forgot the references page. So this is actually the last page, and that's all I got. So I really do appreciate it, and I hope you have a great evening.